Welcome everyone to the Hobby School of Public Affairs Hobby Hour. My name is Jim Granato and I am Dean of the Hobby School of Public Affairs at the University of Houston. For this month's Hobby Hour, we are excited to be partnering with the Texas Tribune Festival and have our event included in the festival's official program. Today we have a speaker of some renown. His name is Dr. Tim Garson. And I'm just going to give you an abridged version of his biography because we'd be here a long time. Dr. Garson has been a visiting scholar in the Department of Health Systems and Population Health Sciences, the UH College of Medicine, and professor of management policy and community health at the University of Texas School of Public Health in Houston. In December 2019, after 5 years, he stepped down as the director of the Health Policy Institute of the Texas Medical Center, home to 59 healthcare institutions in Houston. He is a pediatric cardiologist trained at Texas Children's and became chief of cardiology there. He's an elected member of the National Academy of Sciences Institute of Medicine. He has been dean at the Baylor College of Medicine, dean of medicine at UVA, and also provost at UVA. He has served as president of the American College of Cardiology. He is the author, among 9 books, of a most recent book, although he's going to have a revision come out soon, and that's what part of our talk today, a good part of our talk today is called Exposing 20 Medical Myths, Why Everything You Know About Healthcare is Wrong and How to Make It Right. Dr. Garson, Tim, it's a pleasure to have you with us today.
Jim, this is terrific. I mean it. I hope you can all hear me. Hi, Andrew. We want this to be fun, folks, the way this works. I mean it. This is really supposed to be interactive. You're going to get to talk. You're going to get to listen to each other. The idea is we've got, 4, 5, 6, 7 things that are either true or false. They're either myth or reality. And we're going to walk through them and you're going to get to vote. You're going to get to take if you look down at the bottom of your screen where it says reactions and you click on that little thing and it says raise hand right at the bottom. That's what would be great if you can do that after we vote. Now, there is a voting thing. So, for example, and again, a real thanks to Jim, there are like 7 people working on this. I've never tried to have 7 people work on anything. It's tough. So thank you. This is great. I'm delighted that the Hobby family put this together because it's needed. It's really important. So thank you, Jim. Thank you all. This ought to be, as I said, this ought to be sort of fun. So here's how it's going to work. I'm going to say, Isaiah's going to put a slide up, if I've got it right, Isaiah.
Yes.
Okay. Wherever it is, you should all be able to see. Is that right? There it is. Okay. Now, here's how this works. You get to vote true or false. You don't get to say, well, what do you mean? Or I don't understand. We got to vote true or false. And you don't have to write your own in. You can vote where it says vote. That's fairly easy. But we're not going to say, okay, Charlene voted true. We're not going to do that. But after you vote, what we then want to do is have a discussion. And I'm going to say, okay, who said true? Who said true that would like to talk about it? Who said false that would like to talk about it? And hopefully what you do is raise your hand. And hopefully if we even can make it work right, you can talk to each other. So I'm going to hopefully talk little. You're going to talk a lot. And yeah, I've got some things to add in. So what you see on your screen, U.S. healthcare is the best in the world. So Isaiah has single choice. Unless you're schizophrenic, you got to answer one or the other. You can't answer both. So either true or false. And I guess Isaiah will tell us about how long we have. But click on one or the other, please. And then just to be clear, how we're going to do this is Isaiah will tell us when it's time, and we will then ask you to literally raise your hands, and we'll talk.
10 more seconds.
Now, well, how neat is that? So, and you're all getting to see that, I assume. And so 13% of you said true. I think it would be really fun to start there. Okay, so if you said true or would like to talk about the true, click on your raise your hand, if you would, please. And then Isaiah will unmute you, demute you, dismute you. He will do something. So please, and this is a subset because of the 13%. Some of you are going to want to say something, I hope. So please do. Don't be shy, because we can all listen and learn from each other. Come on. Nobody? I'm sure there are going to be plenty of people that would like to speak to the false side. Let me, if I may.
I think Andy Marks has his hand up.
Oh, great. Okay, let me make sure just so I can get it right. Golly. That may be a technology issue because I don't see Andy Marks's hand. But anyway, Isaiah, go for it, please. Andy Marks.
Well, I didn't put true, but I didn't put I didn't put it, but just since no one else seemed to do it, I figured someone had to bite the bullet.
Sure.
But what I'll say for someone who might argue that it's true is if you do have insurance, particularly very good insurance, you will get access to really, really good care here. I mean, the doctors we have are outstanding. The treatments we have are all very good. You know, there's a reason why people come from all over the world to, for here to get treatment. Granted, there are a lot of barriers to that. Like if you don't have insurance, well, not so much, or you don't have the money for it, it's a bigger problem. But if you do have those things, you will have access to very good care.
Terrific.
And a lot more.
Who would like to speak to the false? Raise your hands. Okay, the first one out of the box, Donald Briscoe, go.
So, first of all, when I'm talking to students, I make the argument that the U.S. doesn't even have a real healthcare system. When I think about a system being something organized with a plan to get a good outcome, I think we have pockets of healthcare systems, Kelsey-Seybold and Intermountain and Kaiser. I think we've got pockets of them, but I don't think we have a great healthcare, a U.S. healthcare system to start with. We certainly spend lots of money. We don't get great outcomes overall. I think we've got the best heroic care system in the world. That's why
I've never heard that. I love that.
When you're at the very end and you can get every organ in your body transplanted, this is the place to come. But I make the argument that we don't have a U.S. healthcare system to start with.
Love it. Someone else on the false side. Leonard Chan.
Hello. Some of y'all already know me for some reason. I would say the life expectancy is lower, but we're paying more per capita than anywhere else. And there's a lack of emphasis on preventive care.
So this is really important. And with a group this size, it's a little bit tough to say, oh, by the way, what's the difference between healthcare and medical care? So I think maybe I'll just dive into that a little bit. The measures of healthcare are life expectancy and infant mortality, okay? That's when people say healthcare. Big numbers, big deal. And there's a paper way back that everybody talks about back in 2002 where they try and talk about, all right, what is it that goes into life expectancy? So when you say, all right, life expectancy, what goes into it? And the answer is, and there are a couple of papers since then, if you sort of synthesize all of it, the sort of two ends are so important. One end is that 40% is what we do to ourselves, right? So 40% of our life expectancy is the stuff you can imagine: smoking, drinking, obesity, murders, all right? The chance of a teenager being killed with a pistol, no offense, and this is just data, in London is 82 times less than in the US. And so that's part of life expectancy. Now, therefore, no immense surprise that our life expectancy is 46th in the world. Oh, yes. And then the other one, infant mortality, is we're 51st. So we're sort of in the 50-50 club. We run around between those two. I think, you know, a few little things to remember for cocktail conversation. The life expectancy of a male in Harlem in New York is lower than the life expectancy in Bangladesh. And so when you talk about healthcare, you're talking big numbers, big sorts of changes. Now, if 40% is what we do to ourselves, and if you look at, in fact, what's happened over the last 3 years with our life expectancy, it's gone down. Would anybody just like to raise their hand and talk about maybe why they think life expectancy may have gone down? Because it has. LaDawn, if you meant to.
I did.
Okay, good.
I think opioid addiction has something to do with it. Probably economic conditions, other social determinants of health.
So the three things are absolutely, and I mean, the great quote is, for the first time since the first time that it happened 3 or 4 years ago, the quote was, for the first time since the Civil War, our life expectancy went down. And that was obesity and diabetes. That was the first year. Now opioids have come in and COVID is coming. And so our overall life expectancy is now terrible. I think it's worth then saying, all right, that's healthcare. And remember, if 40% of our life expectancy is what we do to ourselves, you go down and social determinants are next, and then environmental and public health. You get down to medical care, which is 10%. Now, the only two estimates I've seen are 10% and 20%. So medical care, the stuff we do, the stuff docs, nurses, patients, clinics, hospitals do, at most 20%. So you'd say, now, as was pointed out early on, if, you know, as Andy said, if you're in Houston, Texas, and you have health insurance, and you can get to the Texas Medical Center, et cetera, et cetera, et cetera, you can do fairly well. That's medical care. So you'd say, well, okay, goodness, our medical care has to be great. No, our medical care, we're 18th out of 18 in the OECD. 18 out of 18. Now, how can that be? Well, that statistic is mortality amenable to medical care. And you'd say, no, that can't be. Oh, yeah, it is. And so we have some really good things we do, right? Breast cancer survival first. Diabetes and ischemic heart disease last. So, and that's the stuff, you know, we like to think of. So I think a takeaway here, and the overall big picture, the Commonwealth Fund that I'm sure you all, probably every one of you on this on the screen know of, Commonwealth Fund is just a tremendous resource. They do studies and stuff. Well, the study that just came out, we are the worst of the 11 richest countries overall. Okay, so not just, healthcare, medical care. And, one might say, well, what's that about? And I think Andy pointed, would anybody like to talk about what's going on here? We've already talked, by the way, about obesity and diabetes and drug abuse. But would anybody want to raise your hand and say, okay, what else? What's going on here? Why is our life expectancy? Brian Reed. Hey, Brian.
Hey, so I mean, we still, I mean, so in the past 2 years, we've got this environmental hazard with this COVID and just how well we've been managing or not managing it. But I wanted to ask about, in those sort of stats, when we talk about the medical care, where do the medical errors fall in there? Because we see these reports about our medical errors.
We're going to see that in the next question.
Okay.
But do you want to talk to it? Is there something you'd like to sort of toss in? Because I may not pay attention to you next time around. Just kidding.
Well, it just, I just think, some of the discoordination and disjointedness of it, allows opportunities for medical mistakes to happen. You have a lot of handoffs and transitions between institutions that aren't necessarily complete. And, each of those, afford an opportunity for something to be missed, a drug interaction or, something overlooked.
I'll give you all the hint just in case. The number is, and it's not that different than when it first came out. It's about, if you filled up a 747, that's many people are killed per day from medical errors. That may be a little more than that, but fill up a 747 and that's about it. Paige. I see a hand, maybe
That's
not.
me. Yeah. I think the biggest problem for me is that healthcare is a public good, right? There are like externalities involved, and because it's a capitalist system and we make money on treating people's illnesses rather than in the promotion of general public health, and we've done so for the last several decades, we have not like created a culture of health in the United States. And so all of these things that we do to ourselves, obesity and diabetes, have, that's a consequence of our food systems and everything else. So there's a long game that's been played in sort of like the development of like the capitalist healthcare system and enterprise that profits from people being sick and staying sick. And if we were to switch the paradigm and say, how do we, as a nation become healthy and profit off like our health, we would put more resources into that sort of like personal education and public health endeavors.
I would bet everybody agrees. As Jim said at the beginning, I've just revised that book, and I'm not any smarter this time around than the last time around what do you do about making money? And I think, I don't want to deal with it a lot because we'll all get it wrong. You can't say in the United States of America, it ain't okay to make money. Of course it is. I will give you, and we will talk about overtreatment in a minute of what goes on. And there is plenty of overtreatment that in fact does make people money. But I would, if anybody would like to take 60 seconds or so and say, all right, here's what you do. And I'm not saying you should, because my goodness, lawyers, architects, all kinds of people make money. The question is there anything of those of you here that could be done about profit motive? And, you all know this, not-for-profit hospitals have very similar incentives to for-profit hospitals. So it's not just let's make everything nonprofit. What does anybody, I haven't turned the book in yet. If anybody's got some ideas, fire them off. It's tough. All right. I don't know either. Okay, let's go to the next one, Isaiah. Sorry. All right, now I want to make sure that the words are clear. If it's less or more, it's false. Not just, is it about 1 in every 10, then it's true. If you think it's 5, if you think it's 55, it's false.
Fifteen more seconds.
Seems long. Oh, wow, neat. Okay. And again, I think it's important we see, less true than false, but who that answered true would like to speak to that? Remember, the majority ain't always right. Wait till we get a few more down the road. That I was telling Jim, the first one of these I did, I was the dean at UVA, and I had a 13 city book tour. And the one in LA, the UVA grads had not seen each other in 3 years, and there was not a sober person in the room. This is more fun but if anybody would like to speak to wasting 10%, please do. Okay, Megan. Howdy, Megan.
Hi, how are you? So I don't know that it's necessarily wasting, but definitely it looks like it's a misallocation if we're saying that only 20% of the outcome is related to medical care, but we're spending so much of the money on, I forget what the exact figure is on the amount, I think 80% is spent on medical versus 20% on community health and social services.
Probably not even that much. You got it.
So there's definitely a mismatch in funds, whether it's defined strictly as waste or not.
Yeah, waste in the easiest way is it doesn't help the patient. That's the easiest. P.S. It gets very dicey when you say it doesn't help the patient enough, because then so it doesn't help the patient. Brian, did you want to speak or not? Brian Reed, no? Brian needs to be unmuted, dismuted. There we go.
Yeah, I just had a hunch it was a higher figure than 10%. I'm thinking probably 20 or 30% is waste. I mean, when you think about all the sort of redundant testing and things that we do, I just figure it's a higher amount.
I'm going to get opinions on that in a minute, so hold on. Donald Briscoe.
Yeah, if we include the repeated tests, the unnecessary treatments, when we look at the choosing wisely things, all of those things that are done, the inappropriate testing, defensive medicine, things like that, I think the number is probably way above 10%. I'm afraid to give a real guess as to what I think, but I think it's way above that.
The number that was well documented by Don Berwick in a paper that should be required reading for life for anybody is in a JAMA article in 2012, pretty well documenting about $1 trillion of waste in the system. And if you sort of gross that up, we spend now in 2020-ish 3.8 trillion. And so waste is around 1.19 trillion. What? And I would like, now just for, you know, we don't deal with those numbers. It's sort of like, if you were able to take everybody who was currently uninsured and insure them, you'd be around 150 to 200 billion. So that's the order of magnitude of what we're talking about. So now please raise your hand if you'd like to talk about what you think are the one or two most important things we waste money in before I at least give you Don Berwick's analysis. Matthew Mosley.
Hi, yes. I'm a public policy student here at UH, so thank you for joining us. And one article we read this week was on overbilling in Medicare, and it was saying at least 3% of the physicians in America will charge a higher code. And so even though they're performing treatment, they're, upbilling the system.
Yeah, the interesting thing, I mean, yes, thank you. Hold on to that thought. More folks, raise your hands. What's the biggest amount of waste that we do? One thing. Don't even have to have two. Andy.
I would say, and this kind of goes with overbilling, but overtreatment of things. Doing all kinds of unnecessary treatments, or even treatments that aren't 100% unnecessary, but are a little bit excessive. And
you're kind. Winston, good morning. We need to demute Winston. There we go.
Hey, yeah, I was gonna say overtreatment too. I guess I'll also add pricing failures. So prices are not transparent, and so you have a lot of variation across geographies, and even like across the street. You can have hospitals that are charging completely different things for the exact same procedure.
Super. Paige? Yeah, we need to unmute Paige. Yes, or not. We had Frank. Paige, can you unmute yourself, or can Isaiah do that? Paige Powell? Could you mime it? Could you sort of go and, just sort of act like you're a mime, because we can't seem to unmute you?
There it is. Thank you.
There we go. Got it.
I said insurance companies. That's the biggest fat in the middle. If we could cut out that middle layer between, providers and the recipients of the medical care, I think single payer is the way to go. That's how a lot of other countries have streamlined their costs. So that would be mine.
There was Frank.
Yes. Can you hear me?
Yes, sir.
Okay. I would like to know, please, the variation across sectors. I live in a large city, and I think that the healthcare is very good in this city. How does it vary by either regions of the country or specific size of the city? Can you speak to that, please?
Sure. And I'm gonna cut to somewhat of a chase, and I hope I'm answering your question. There was an article, very, very telling article by Atul Gawande in the New Yorker 10 years ago, who pointed out that, and it was interesting, it was not the highest, it was the second highest in the country in McAllen, Texas. So the cost of healthcare per person in McAllen, Texas was the second highest in the country. And I'm embarrassed to don't remember what the heck the first highest was. And when you dive into that, it turns out, and I'm gonna, give the docs credit or non-credit. I think many did not realize what they're doing. They just did it. that they ordered tests, they refer to people, they do procedures, because that's just the way everybody does it in McAllen, I think. Now, a little bit less favorable is the fact that our very own folks at the School of Public Health here said, all right, we know that Otogawande came out, those are Medicare patients. What would happen if you just did Blue Cross Blue Shield? And let's look at whether McAllen, Texas is the second highest in the country in Blue Cross Blue Shield. Well, you know why I'm spending the time, it's not. And so Medicare, where you have very, very little supervision, you just do it. Blue Cross Blue Shield, where you have a lot of supervision, you can't just do it. And so I think you'd wind up saying, these docs do know what they're doing. And this was long enough ago that probably 90% of them aren't still practicing anyway. But that's the data. And I think what you'd see is on the high end, Frank, I hope I'm answering this to you. On the high end, if you look at variation in spine surgery, it's about 6 times from the highest to the lowest per person, adjusted for how healthy you are. It's about 6x. For some cardiovascular procedures, it's about 3x, meaning, and Miami, of course, leading the world. Miami, as in Florida, having 3 times the per person rate of coronary bypass, stent placement than Oregon seems lower. So that's the variation. I have been amazed that when you look across the country and you look at the variation, more is never better. You'd think somewhere, if you did, more spine surgery, the results would be better. They're not. So let's dive in to what Don Berwick found. And if we say we're going to now try and account for $1.19 trillion, administrative waste, number 1. Now, what does that mean? Well, you all know what that means. I could ask you, but we got a lot to cover. So let me just give you a couple of examples. 4-star, it's $310 billion. 310 billion. Remember, covering the uninsured is half of that. If you just cut administrative waste in half, you're done. Now, what does that mean? It's the stuff Andy's been talking about. It's some of the stuff is you do one test and you can't get the test result. Unfortunately, it's not quite that positive, because you go to hospital X and they say, yeah, I got that echo, but it ain't any good. I got to do mine. What? That MRI, yeah, I can get that. No, I got to repeat it. And so not all of it is you can't find it. And so I think on the big end, again, there are many of you I know are a lot smarter than I about, all right, how could we get an electronic health record that actually helped doctors and patients? Because right now it doesn't. Just think about how many times you walk into the doc's office and they don't even know what your name is, and they sure don't know what your address is. And even worse, folks, right? You walk into the same system in the morning and the afternoon, and they don't know who you are. So the administrative waste associated with lousy electronic health records is serious, as in, it's probably 200 billion. The amount we spend on administrative waste is about 2x of Canada, and or on administration, not just waste. All right, now back to Andy's point. Next in line, 240 billion in overtreatment. Now, that gets complicated. I'll start with a statistic. that when you ask a bunch of docs, this was published in JAMA maybe 3 years ago, and you say, okay, not you, Charlene, how many of the docs that you know, not you, overdo stuff to make money? Not you. 72% say, oh yeah, somebody out there that I know. Now, is that unusual? No. Is it unfair? No. I mean, there are all kinds of things, but it's very complicated because there are multiple, that's just data for you. There are multiple sort of drivers of why docs do stuff. And it's not just money, it's not just malpractice. To tease that apart is really, it turns out I was part of a group in DC where they said, could you look at a medical record? Could you look at somebody's chart and tell if the doc was practicing defensive medicine? You know, they got a CT scan because the kid came into the ER with a whack on the head. And the answer is no. You cannot tell just by looking at a chart. So what do you have to do? You gotta ask them why they did it. ... Right? Good luck. So now it's only fair to say patients are part of this too, folks. Right? Doc, I gotta have this test because I saw it on the internet. Doc, I gotta have this medicine because I know it's going to do me some good. And there is one study of a group of doctors that actually said, as long as the drug would not hurt the patient, they were inclined to agree with them and just give it to them. This is published, rather than just saying, you know, no, I'm going to spend 10 minutes trying to talk you out. So this is docs and patients. Now, the interesting thing to me, and Jim said, what did I learn new about the new part of the book? I never looked at overtreatment internationally. And I said, you know, I wonder whether they do this in wherever. Well, damned if the United Kingdom government didn't go look very carefully at the private system in the UK. Not the public system, not the National Health Service, not what you do in the morning. It's what you do in the afternoon when you're in your own private office. And the answer is the same stuff. So it goes on, and yes, there's plenty of malpractice issues in England as well. So, but and suffice to say, the data are, yep, the same in France, yep, the same in Germany. There is overtreatment in the public system in a lot of places. The private system, there is plenty of overtreatment as well. Presumably, I mean, obviously, that ain't about money. And so it gets to be very interesting. Why do you do that? You know, why did you do that bunch of tests? And it is interesting because, you know, I just want to make sure I got it right. Okay. All right. Fraud. The F word, fraud. 219 billion. What? All right. And as you said, overtreatment, you know, upcoding is the favorite word. You see a patient for 3 minutes and you charge as if you saw them for 30 minutes. That's upcoding. There are the estimate is about 10% of Medicare billings have some part of it that's fraudulent. What? Now Medicare is a big payer. Those of you over 65, just kidding, me, you know, Medicare is a big payer. For 10% of the bills to have something fraudulent in them is a little bit frightening. Okay, price. The easy way, and you know, Uwe Reinhardt, who was just one of the neat guys of the whole world, economics professor at Princeton, published a paper with Jerry Anderson that said, it's the prices, stupid. It is. And so if you look at virtually anything, it's 3x. So the drug prices here are 3x Europe, 3x. One of my very, very good friends, who's the chief of pediatric cardiology in Paris, who was really not allowed to have private practice. And so he and I sort of had the same deal. I made 3 times what he did. And so think, just let that number sort of sink in. It's about 3x, and approaching drug pricing is important, right? Approaching drug pricing. Interestingly to me, and this is just data, I don't really have an opinion. There was a study a long time ago, probably 10 years ago, that said that if Medicare was permitted to negotiate drug prices, wait for it, the effect would be very little. And this is just one study, but if you think about all you know about the ins and outs of how drugs are priced and rebates and upside downs and all of this stuff, there is a lot that is done already. And so that's not to say drug prices shouldn't be cut by 2/3. They should. I'm not 100%. This is just one study, and opinion, like all the rest of us, hasn't been. You've got to be able to figure out how to let Medicare negotiate. Now, here's something you may not know. In statute, as in written in the law in Medicare, they are not permitted to consider price in what they cover. What? Medicare is not permitted to consider what they charge in what they cover. It's in the statute. Now, even worse, when the Affordable Care Act, I mean, there are all these deals that happen. In the Affordable Care Act, there is something called cost effectiveness, right? Cost effectiveness means, what does something cost divided by how good is it? How many years does it prolong your life? Not allowed to use that. Not allowed to use cost effectiveness. And so the government, now private payers do, commercial payers do. Let me give you one example of how this works. And it works not as well as you'd like, but it works better than here. The British have something called NICE, N-I-C-E. And NICE is the National Institute for Healthcare and Clinical Excellence. Now, they keep changing what NICE stands for, whatever. Basically, they're the agency that decides what the government will pay for and how much they'll pay for it in drugs. Makes sense. That was one of the early proposals by the president, was to do that. As you can imagine, the drug companies just go ballistic on thinking that one might actually do that. There are lots of approaches to reducing the price of lots of things. Recognize, if we overspend, and safety is about 154 billion, and care coordination that one of you mentioned is around 60 billion. Care coordinations is admissions and readmissions that don't need to happen. It's probably a low number. And so there are lots of approaches. Safety, just to go back there, between 1 and 3% of every hospitalization, either you die or you're harmed because of an error. What? And this isn't on purpose. This is twice a day in the United States, somebody takes the wrong thing off. Twice a day in the United States. Wrong kidney, wrong arm, wrong nose, maybe not, wrong eye. Okay, so things happen. Care coordination, I'm gonna leave carefully. I have this thing, I wanna be careful, but I started this group called Grandaids that does exactly that. And there's a lot of readmissions that can be reduced simply by, helping people to know what medicines they're taking. Okay, next one, Isaiah, we've only got 15 minutes, maybe 10, because we need Jim to get back involved. This isn't a bad one to make everybody angry. So preventive care saves money. True or false? Now, of note, while you're still answering, this is not preventive care is good for you. This is preventive care saves money.
I'm going to end this one a little early just because we are running late.
I can do goals in about 35 seconds. Okay. Now, who would like, I'll flip it. Who would put their hand up, please? Thank you, Isaiah, about true. Who said true that would like to say, why does preventive care saves money, or how? Think that you're in a bar and talking to somebody. Just raise your hand, it's okay. Or if not in a bar, you know, you're wearing a mask or something. But you said preventive care saves money. How? Natalia.
Hi there.
Hey.
I was thinking of the adage, what is it? An ounce of prevention is worth a pound of cure.
I'll buy that. Not sure it saves the pound if you're in Britain, but others. But thank you. Matthew.
I think one thing that I always think of is if we made annual preventative exams, say, completely covered for everyone, if they go in and they get a checkup on a yearly basis, maybe we can catch and start treating an illness or any kind of problem before it turns into a bigger issue that will cost more money down the road.
Fair enough. That smacks a little of the wellness programs that are out there in businesses, like 84% of every large employer has a wellness program. We'll come back to that. Other people that would like to speak. Okay, a few bullet points. The Robert Wood Johnson Foundation, fairly good folks, reviewed 500 studies on cost and cost effectiveness of preventive care. Two things that are done actually save money. 2, childhood immunizations and baby aspirin for adults. That's it. No, really? Yeah. And so how does that work? Very quickly, because I want to do one and then I want to get back to Jim. Let me give you the one that just blew me away, because there's a lot of stuff, but suffice to say that in hypertension, you know, there's 43 million people with hypertension. A very, very, very small percent of those folks are going to have strokes and heart attacks. And so the issue is trying to figure out, one of the issues with prevention is, can you somehow get a better idea of who's going to die, who's going to have a stroke, rather than saying, okay, let's treat 46 million people. So that's one of the issues. I got to tell you the smoking thing, because it's really important. All right. Baumgartner, New England Journal of Medicine. Of all things, the Congressional Budget Office, whoever thought the Congressional Budget Office, you know, was going to tell you anything you wanted to know. Well, this is an amazing study. They decided that they would figure out what would happen 30 years down the road, if you increase the cigarette tax by 50 cents a pack. Okay, what would happen? Now, you know why I'm telling you this. And the answer is 30 years down the road, smoking saves money because it kills people. And so, and you'd say, oh, come on, no, this is serious, because when you're doing big picture Medicare things, you have to worry about stuff like that. All right, you do. And so the longer, there's this great quote about, the expensive child who dies does not grow up to be an even more expensive adult. Now that's horrible, right? Please don't leave this and say that moron. You can say that moron any way you want, but that moron told me preventive care is bad. No, the moron did not say that. The moron said it costs money. So it does. The things one of you just asked about diets. Yes. That's the problem, by the way, with wellness programs is, I'll give you the data. I mean, everybody would think, including me, that wellness programs, best thing in the world. You show the employees you care. Penn State University got sued by its employees because they had a wellness program that would not leave people alone. And it got the employee, well, you got to do this, you got to do this, you got to do this. Well, it turns out when the folks at Kaiser went and looked at it, there are 43,000 employees, and they came down to 100 inpatient visits in those 43,000, in the 43,000 who were in the program. Of those 100, the vast majority were in people who already were identified. And so there's problem A there. Problem B is, okay, you identify somebody's cholesterol at 300 today, and they're 28 years old. So you get them on, good luck, 50% of people don't take it. But you say, okay, take your medicine. And then you go look at, okay, how much money did the X company save because they identified Charlene's high cholesterol? And the answer is nothing, because she doesn't have a problem for another 35 years. And so again, there's nothing wrong with health, with wellness companies. Just be a little bit, go look at the literature. It ain't as wonderful as you might think. COVID, by the way, is, and so this study by Robert Wood Johnson was, and I'm going to give you the 5 minutes in 2.5 minutes, Jim. COVID was not, extant at the time of that RWJ study. There is a very interesting study of all things that came out of South Africa that did look at cost effectiveness of the COVID vaccine. And it is cost effective and money saving. So that's another one that you can put in the win column for preventive care saves money. The last one, real quick, Isaiah, and I've got 1.5 minutes, the one on goals. All right, the answer is, that's really interesting. We could spend 1.5 hours on this, except Jim won't let me. Let me very quickly, because this would be great to discuss, let me very quickly tell you at least what I was thinking. What does everybody on this seminar want for themselves? They want health insurance. They want to be able to afford it. They want to be healthy, and they want their health care to be good. They want access to a doc or a nurse practitioner. Everybody on this I would think, wants those same things. What does the United States of America want? The same thing. They want everybody to be healthy. They want everybody to have health insurance. They want it to be affordable for the country, for insurers, for whatever. And they want to quit being in the 50-50 club with quality. So the punchline here is we all want the same thing, but oh boy, good luck figuring out how to get there. So on that note, I turn it back to Jim, and this has been fun. So thank you all, and back to you.
Thank you very much, Tim. I mean, that was fabulous, and we could have talked for another couple hours, I think, about these issues. For those of you that have been participating today, please mark your calendars for our next hobby hour. It will be Wednesday, October 20th at noon, and we will send you a link to that. And that hobby hour will be joined by former Congressman Gene Green and former Congressman Ted Poe. Amongst the topics will be their past experiences serving in Congress, the current situation, issues concerning bipartisanship, their friendship, and something else I think is quite interesting, the day in the life of a congressman and congresswoman, what it's like living in Washington. I mean, an example, Representative Green, he had an apartment that was 380 square feet. That's where he lived in Washington. So it was just that kind of thing, you know, the time demands and things of that sort. It'd be interesting to see what they had to say, these two veterans of public service. I also want to thank Maria Arriaga, Chelsea O'Hara, Celeste Zamora, Diana Benitez, Emily Janowski, and Isaiah Warner for helping put this together, and our partners at the Texas Tribune Festival. I'm Jim Granato, Dean of the Hobby School. Until next time.